Jaslok Hospital, the Breach Candy Hospital, and ACI Kambala Hill, among others. I am a specialist laparoscopic surgeon and I specialize in the treatment of endometriosis. I also run an endometriosis center, which is an international multidisciplinary referral center for advanced endometriosis cases that treats patients from all across India and around the world. Endometriosis is a disease that is very common. It affects 1 out of 10 people assigned female at birth, which makes it about as common as diabetes. Yet the awareness is very poor because the disease predominantly affects women. So there is not too much awareness about this disease. We know that women have historically been led to believe that period pain and pain associated with menstruation is normal. But if the pain is bad enough to require medication or affect social life or academic career or work life, then that is not normal and warrants the specialist. A young lady complaining of painful periods is often met with gaslighting from family and from doctors as well. And they are rubbished with sentences like, it's part of becoming a woman. And, once you grow up and get married and have babies, then everything will be okay. So this is nothing could be further from the truth, because this never resolves, and this just allows disease to progress and reach and produce irreparable damage. Endometriosis is a condition where tissue that somewhat resembles the lining of the uterus, also known as the endometrium, may occur outside the uterus. This is not caused, as what is taught in medical school, by retrograde menstruation or flow of blood during menstruation. But there are many other theories that have proven to be the cause of endometriosis. Now, endometriosis also is a lot more complex than just the chocolate cysts or the ovarian endometriosis that is commonly treated in gynecological circles. There is superficial endometriosis that affects the peritoneum, and which is the lining. It's a filmy layer that covers the organs of the abdomen and pelvis. And also there is deep endometriosis, which is severe fibrotic disease that can have tremendous consequences and can affect the intestines, the rectum, the small bowel, the appendix, the ureters, the kidney, the bladder, the diaphragm, the lungs, and the heart as well. So it is not just a gynecological disease, it is a multi-systemic disease, and that is why these kind of conditions, especially advanced disease, needs to be dealt with specialized endometriosis center, because it is beyond the gamut of routine gynecology. So when we talk about causes, we don't know exactly what causes it. Of course, the old theory, which is normally taught, is retrograde menstruation or the backward flow of blood, but that does not explain how so many different presentations of the disease may occur. We more popularly accept theories such as Mullerianosis, which is basically when an embryo is forming, there are certain tracts down along which these cells are laid, and among certain epigenetic factors, when one attains puberty, that these tissues start to produce, and that leads to a repeated cycle of tissue injury and repair, which causes the sequelae of scarification and fibrosis, which in turn leads to the entrapment of nerves and increase in the thickness and the number of nerve fibers, which is basically what causes 90% of women with endometriosis present with some form of pain, while only about 30 to 40% present with fertility issues. And that is easily corrected by restoring the anatomy. The main problem is that even in a country like ours, and this is a worldwide problem as well, that most women coming to the doctor with pain have their conversations being rerouted towards come in with difficulty to get pregnant, the doctors are more or less telling them, go and get pregnant, go and have babies, and everything would be fine. So, of course, this is going to lead to a misdiagnosis because not all women are going to have problems conceiving. Is really putting women's pain on the back burner, which is got irrevocable long-term damages on socio-economic factors as well. That there is disease on the back of the vagina where the rectum may be adherent. If there is endometriosis in the bowel, it may cause constipation and or diarrhea and bloating of the abdomen, known as the endobelly. There may be vegetative symptoms such as chronic fatigue, anxiety. This occurs due to a hyperstimulation of the nerves along a particular area. Like I mentioned before, few women may have difficulty getting pregnant due to the distortion of the anatomy between the fallopian tubes and the ovaries, and also the presence of cysts within the ovaries. Of course, some women may be completely asymptomatic and have advanced disease as well. So the degree or stages of endometriosis have nothing to do with how bad the symptoms may be. There's when we talk about diagnosis, is there a simple way to diagnose this? The most important way to diagnose endometriosis is to listen to your patient. So if your patient is telling you she's in an inexplicable amount of pain and it's causing her distress and ruining her quality of life, that should be the first warning sign that you may be dealing with a case of endometriosis. And unfortunately, what is taught in medical schools is to work the other way around. And I've seen OBGYN practitioners go out of their way to prove that it is everything else but endometriosis before actually looking and treating for endometriosis. What I mean to say is that a woman presenting with pain, apart from having their conversations rerouted to fertility, are either put on NSAID or over-the-counter painkillers or birth control, and they are not offered the correct surgical removal of the disease immediately unless they are looking to get pregnant, which is a travesty of justice in the medical field, in my opinion, and does need an immediate rectification as well. So, of course, imaging is very advanced nowadays. So, ultrasounds and MRIs can pick up endometriosis, especially deep endometriosis and ovarian endometriosis. Superficial lesions may not be seen on imaging. So, but not all ultrasounds and not all MRIs are equal. Just like not all surgeries are equal and require specialized training, as does that the ultrasound and the MRI require specialists trained in identification of endometriosis to make the diagnosis. I've seen hundreds of patients with reports from all across the world which have missed the diagnosis completely and reported no endometriosis, and they have completely missed huge nodules of endometriosis. So that's the diagnosis also has to be made in a specialized center with radiologists or gynecologists or ultrasound specialists trained in identifying the disease. As is the treatments also. The surgery is technically the most difficult surgery to perform in gynecology, and the gynecologists need, apart from specialized training in laparoscopy, require specialized training in endometriosis to be able to deal with this. Okay, now we are going to open up to questions. So we have one question which said, I had one cyst and after 4 years developed another. Symptoms so far are period farts and bloating. I also feel a bit sore during periods. Is there no cure for this? I heard it will get worse over. So that's an interesting thing. So bloating is a very worrisome symptom for me. It's usually significant for disease affecting the bowel directly, or it's affecting the nerves that supply the bowel, which is causing a high hyperstimulation of the intestines. The cure I also feel a bit sore during periods. Is there no cure for this? The cure is surgical excision of the disease, or it's actually correct identification of the disease processes, and then surgical, which is done by a laparoscopy or robotic surgery, depending on which part of the world you're in and what your surgeon's preference is the correct treatment to have it excised. Medical therapies for endometriosis are majorly symptomatic management. They are only to control symptoms. They do not cause regression or halt of progression of disease. They will. There is no evidence to show that lesions reduce in size or regress in size on medical therapies. The next question is, will endometriosis affect my ability to become pregnant? So, endometriosis does cause subfertility or um, even infertility in some patients, but this is a much smaller number. About 1/3 of patients may have difficulty conceiving due to the presence of endometriomas or chocolate cysts within the ovaries, which can have an inflammatory effect, and also disease outside. So, for example, colorectal disease in the rectum can, due to the inflammatory processes happening, render a non-friendly environment for fertility. So there is a good study by Professor Roman out of France, which shows around 400 and something patients with bowel disease who, after excision of the surgery, 2/3 of these patients got pregnant naturally, and the remaining 1/3 required IVF. And obviously, that is due to probably very damaged tubes or some other factor of infertility. So it's not natural to assume that women with endometriosis are infertile and they shouldn't be just directed towards IVF treatments, because I believe a surgery before the IVF is mandatory to rule out and then to assess whether there is a chance to correct the endometriosis and to restore the anatomy and to give that young lady a chance to get pregnant naturally before referring to an ART center. Do I need medications to treat endometriosis is another question. Like I said, medications are useful in treating endometriosis symptomatically, as in they do not treat the disease, they treat the symptoms, which is and the way they work is most medications for endometriosis will trick the body into thinking that it's either pregnant or in menopause. So both of those states suppress estrogen, and they will avoid the estrogen related flare ups of endometriosis. And this may only work in some cases of endometriosis, depending on what kind of progesterone receptors and progesterone sensitivity there is for endometriosis. So those are what medications do. So medications are a good way to delay surgery if there's, for example, a pandemic going on and patients are unable to travel to Bombay to get treated, as has happened in the past couple of years. So then those patients benefit from medical therapy to keep their symptoms under control. Post-operative suppression of ovulation is useful to prevent to improve pain outcomes and also to prevent the recurrence of cysts. And on to the next question. What are the risk factors for endometriosis? I am 38 years old. So I don't really subscribe to the risk factors that are presented in medical literature. There's not very much evidence backing the risk factors. For example, one of the popular quotes of endometriosis is quite misogynistic in its being, and it says, endometriosis is the fruits of virtue and fibroids are the fruit of sin. Something to that effect, which is quite terrible in itself to say, and it has absolutely no bearing to the truth. So there is, in my opinion, there is no risk factor for endometriosis. There is a genetic linkage of endometriosis, as in the gene may be transmitted directly from, say, mother to daughter and mother to uh, twin daughters or sisters or whatever. The gene may be transferred, but that does not necessarily mean that the daughter or the sibling may present with endometriosis or present with the same kind of endometriosis. So those factors are dependent on epigenetic factors, which can be environmental factors, and also a lot of how would you say, hormonal changes on a cellular level and hormonal patterns. So that's why you see hyperestrogenic conditions such as fibroids, adenomyosis, PCOS, and endometriosis are very common among the same group of individuals. So because those are very hormonally dependent conditions, you may see all or a combination of all of them in one particular patient. Mhm. Um, I don't think we have any other risk factors from there. Um, I don't know if there are any more questions. So somebody commented that we have no issues with bowel movements so far. Right, great question. The disease can reoccur. That's a phenomenal question, and I'm very happy that this is asked, because this is often used. So the myth that endometriosis is chronic, to do surgery at all and to get pregnant, and is these things kind of perpetuate and delay treatments for patients. So when you talk about recurrence rates and you look at with a very wide lens and you look at the worldwide literature for endometriosis, where everybody with a medical degree is doing surgery for this kind of disease, the recurrence rates range from 50% to 80%, which is probably as bad as not doing surgery. But if you kind of narrow down that lens and you start looking at very specialized centers that deal only with endometriosis, you see recurrence rates in the single digits, so like 5% or whatever. And excuse me. So when you have a very specialized center dealing with endometriosis, it is those surgeons that are trained in identifying all lesions and correctly excising and removing all lesions from their roots, which is what completely reduces your recurrence rates. So it's very important to understand the difference between true recurrence of disease versus disease being left behind or persistence of disease. For example, if somebody goes in and does a surgery and leaves a whole bunch of endometriosis behind, it's not a recurrent disease that comes back and continues to be symptomatic. It's persistent disease. For example, if you have appendicitis and I go in and remove an ovary, you will still have appendicitis at the end of the day. So that being said, a hysterectomy is not a cure for endometriosis in the absence of uterine disease, such as adenomyosis or fibroids or endometrial cancers or whatever. So, endometriosis by definition is outside the uterus. So, removing the uterus is not going to treat the endometriosis. Of course, hysterectomies are offered to patients with adenomyosis and fibroids in the presence of endometriosis, but just treating the adenomyosis and the fibroids via hysterectomy and leaving the endometriosis behind is a huge injustice to this patient, because they will continue to have symptoms and require an even more difficult, complex surgery after the hysterectomy. And I think we have ended our talk with the questions for that. If you want, when I talk about a multidisciplinary approach for endometriosis, there is a, just like when ovarian cancer became recognized as a subspecialty and they required a multidisciplinary approach for that, the outcomes of surgeries and treatments for that dramatically increased when there was a specialized team dealing with it. So endometriosis is of course, not as severe a disease as ovarian cancer, but technically, surgically, it is a much more difficult disease to deal with than especially advanced endometriosis. It is definitely not a single specialty disease. It needs a multidisciplinary approach. For example, I work with a very well specialized team of colorectal surgeons, urologists, pain management specialists, anesthesiologists, cardiothoracic surgeons to deal with endometriosis of the chest, infertility specialists, of course, to deal with the reproductive issues, and imaging specialists, radiologists, and sonologists, and also physiotherapists that do help with post-operative recoveries. So we have a very specialized approach, and everybody brings their own skill set to this team that is able to offer patients a much more holistic approach to this disease. One of the questions I also get asked is about diet for endometriosis. Yes, there is a role, and there's much more research going into the microbiome and disease of the gut. Where so we do have a nutritionist as well to work with our patients, and the the I would my advice would be to kind of tailor what works for you, what causes inflammation, what causes the bloating, and to cut those out and slowly, and of course, see a specialist and work with the team to figure out the right course of treatment for you. Um, and lastly, I would like to end saying that a lot of people would say if a big red flag for patients should be if a doctor is directing you towards a pregnancy to solve endometriosis or endometriosis related pain. So that's a big red flag, and you don't walk out of their office. I advise you to run out of that office. Right? I think we can end our session here, and I thank everybody for tuning in. And we can, if you would like to know more about endometriosis, you can uh, visit our website for the Indian Center of Endometriosis, which is endometriosis-india.com, or follow us on Instagram. We put out very informative um, posts and about spreading awareness about this disease, because it does need its own subspecialty, and a lot more needs to be done in terms of awareness for that. So I urge you to do some reading on that. Thank you very much, and have a good evening.